which accounts to 0.9% of total blindness in our country. And yes, this can be very easily eliminated by corneal transplants in a country within a year, which has a death rate of 1,51,000 annually just by road accidents. So why are we lagging behind? And that is the reason in this month of October, we decided to have the theme of cornea. Eye is one of the most important sense organ and is a gateway to the light and beauty of the world. The first structure of the eye which allows, rather permits this ray of light and hope to enter our eyes is cornea. And that is why the theme of our today's episode is the clear corneal route to vision. We wish to bring to the notice of our today's guest that this is not just a platform for quizzing for students and quiz lovers, as the quiz intends to clarify and discuss the relevant points initiated by that particular question in the quiz. Further, the trivia is in the form of Pearl of the Month from our respected guests who are the masters in their field of in their subspecialty field of ophthalmology is wisdom packed capsules, which further enriches our viewers. We are privileged today to have Dr. M. Srinivasan, Chief Cornea Surgeon and a founding member of Arvind Eye Care, and more importantly, the member of our two co-hosts, Dr. Madhu and Dr. Ramya. Also privileged to also have with us is Dr. Virendra Sangwan sir, another doyen in the field of cornea, who is currently the Director of Innovations, Shroff Charity Eye Hospital, Delhi. Also, we are proud to welcome Dr. Rupal Shah, also fondly known as the Smile Woman, not for her sweet smile only, but because she was the first to perform single incision relax smile procedure in our country. Thank you, sir and ma'am, for sparing your valuable time on a Sunday afternoon for our small effort that is Brain Teasers. This time, I have a company of 4 young budding cornea surgeons as my co-host. These young cornea tugs are core members of our gang of Brain Teasers, and today's quiz is conceived by them. I welcome on board today Dr. Madhu Udaraju from Kakinada, Andhra Pradesh, Dr. Ramya from Vizag, Andhra Pradesh, Dr. Mamta Singh from RIO Patna, and our own Dr. Palak Kasumgar from Nagpur. Yes, friends, we are available on Facebook and YouTube, where once you can retrieve previous as well as this program. Sharing the mantle today, we also have Dr. Shilpi as my co-host. Request now Dr. Shilpi to familiarize the participants with the rules of the game.
Thank you, sir. So, good evening, friends. Welcome back. It's time for the rules. So, rules are who can participate. Yes, any ophthalmologist from a PG to practitioner, from kids in ophthalmology to the great veterans. Quiz has 5 sections, with each section have 5 questions in it, and only one amongst the 4 option is the correct answer. So first you have to select the correct answer and then also press the save button to record your answer. I repeat, you have to select the correct answer and then also press the save button to record your answer. Don't be in a hurry to press the save button if you are not sure of the correct response, because once you press save, you cannot change your response. Now this is what you will see on your screen. This is a sample question for your understanding. Identify the character shown in the picture below. Option A, Tom. Option B, Jerry. Option C, Donald. Option D, none of the above. And your time starts now. This timer will play for 20 seconds. You have to record your response only after the timer starts. If you submit your response before the timer starts, it will not be recorded. Now, the answer here is B. So you first have to click the option B and remember to press the save button to record your response. So for correct assessment, there are 2 options. Naturally, the one who corrects who answers the correct response and answers fastest. That is fastest finger first. Every section will have one winner. So it means we have total 5 section winners, and that's not all. For the whole of the session of 25 questions, we have 2 mega prizes, one for the runner-up and one for the winner in for today's session. That means in total, we have 5 section winners, 1 runner-up and 1 winner. But remember, you can be a section winner only for one section. But don't give up, as you can win the session prize with your consistent performance. But if there is a tie, the cumulative performance of all the 5 sections will be considered. And if there is a tie for the session winner or the runner-up, then this ties will decide your fate. In case of any discrepancy, the judge's decision will be the binding. Now look, what is at stake today? Amazon gift voucher of rupees 1500 for every section winner. Runner-up will get a gift voucher of rupees 5000 and the winner will carry away the prize of rupees 7000. It's not only the gifts. Winners, you will be invited live for the concluding ceremony where you will share the screen and interact with our today's guests who are the who's who in ophthalmology. So winners, be alert. Please keep your mobiles ready as you will be sent a Zoom link on your registered mobile number. You will have to join the platform as soon as you get the confirmation. So tighten your seat belts and ready for the quiz. Now I invite Dr. Madhu Udaraza, trained cornea and anterior segment surgeon from Arvind Eye Institute. At such a young age, he is director of so many institutes. Over to you, sir.
Thank you, ma'am, for the kind introduction. Thank you, team Brain Teasers, and also Prashant Bhavankule sir for this wonderful opportunity. It's really a honor to be part of this quiz along with the legends in ophthalmology like MS sir, Sangwan sir, and Rupal Shah madam. And I'm truly fortunate to be a part of this. So without much delay, let us go to the section 1. So in section 1, the first question is, interpret the following anterior segment OCT. Failed, option A is failed DSEC. Option B is Descemet's membrane detachment. Option C is post-LASIK ectasia. Option D is membranes in the anterior chamber. And your time starts now. And the correct answer is, it's the Descemet's membrane detachment. So this is how a Descemet's membrane detachment looks on the ASOCT. Usually a Descemet's membrane detachment will have the attachment in the peripheral cornea, and in the central cornea, you'll have this undulating membranes or straight lines. Whereas in case of a failed DSEC, that will be more thicker. The lenticule will be more thicker, like you can see here. And keratoconus doesn't have any detachments as say. So the correct answer is Descemet's membrane detachment. So the next question is, in which condition do you see the reversal appearance in specular microscopy? That is, the cells are dark and the intercellular borders are light. The options are A, Fuchs endothelial dystrophy, B, ICE syndrome, C, keratoconus, D, lattice dystrophy. And your time starts now. correct answer is ICE syndrome. So in ICE syndrome, you have this reversal appearance. The mosaic becomes non-existent and the cells become rounded up in appearance, with this typical cells becoming dark and intercellular borders becoming light. And if you see to this picture here on slit lamp, this is how the guttae will look on Fuchs endothelial dystrophy. And those are those spaces that you can appreciate on the specular microscopy also. So in keratoconus and dystrophy, there will be no endothelial changes that you can appreciate. So let's go to the next question. Laser scanning confocal microscopy, that is in vivo confocal microscopy, has an axial resolution of how many microns? A, 4 microns, B, 14 microns, C, 26 microns, D, 1 micron. And your time starts now. And the correct answer is 1 micron. The laser scanning microscopy has a very high resolution that it can almost slice the cornea into a volume scans of 50 microns each, and each of these 50 micron scan will have 50 slides in which you can see each slide. So almost in the 500 microns of cornea, each and every layer you'll be able to clearly delineate with this instrument. In the tandem scanning confocal microscopy, the axial resolution is 9 microns. However, it is a older technology where the contrast is poorer. Then you have the scanning slit confocal microscopy, also called as confoscan. And this has a good contrast. However, its axial resolution is limited only to 26 microns. Coming to the laser scanning microscope from Heidelberg, into which we attack a rockstock cornea module, RCM, the axial resolution is 1 micron while maintaining a good contrast. So if you can see in the picture here, almost you can see all the layers that are depicted in the epithelium and below, including the subbasal nerve plexus. Let us go to the fourth question. How many days can we store a donor cornea in cornisol medium? That is our own medium that is produced in India. A, 5 days, B, 7 days, C, 14 days, D, 30 days. And your time starts now. And the correct answer is 14 days. So MK medium, which is also available with us in India, has a shorter period of 4 days. Cornisol and Optisol have 14 days storage period, and Cornisol is what we commonly use in India. Let us go to the last question in this section. Identify the organism that you see in gram stain. The options are A, fungal filaments, B, nocardia, C, microsporidia, D, gram-positive cocci in chains. And your time starts now. And the correct answer is nocardia. So it is very easy to confuse nocardia with fungus. But however, if you see in this slide, the fungal filaments would be more thicker and they'll be broader when compared to nocardial structures, which are more thread-like and they're dot-like connections. So it is very easy to get confused between nocardia and fungus. So especially when you're asking for a stain or culture report, if you can give the history also properly, it will be useful for the microbiologist to give you the correct diagnosis. And the last picture here you see is of microsporidia, which are grain-like with gram-positive stain. So that finishes our section 1. Now it gives me immense pleasure to introduce our own teacher, Dr. MS Sir, as he is fondly called. I don't consider myself eligible even for introducing him. We are all fortunate to have studied under him. As all of you know, he is the founding member of the Aravind Group and he is the Director Emeritus. He started the Cornea clinic in Aravind and he is the doyen in the field of cornea and eye banking in India and also a worldwide authority on infectious keratitis. He has published more than 200 articles in several international journals and he has won several lifetime achievement awards from various ophthalmic societies and also won several prestigious international, national and state level awards. It would not be an exaggeration if I tell you that if you are reading a chapter on infectious keratitis or if you are even reading a journal on infectious keratitis, rarely you can get away without quoting his work in the article. He has done so much of work in infectious keratitis and we are truly honored to have learned from Sir. And I think today's delegates who are attending are also very fortunate because what you're going to hear in the next few minutes is his years of experience distilled into pearls of wisdom. And more important than that, he's a clinician par excellence, is an extraordinary surgeon, and above all, a very, very humble human being. And we are very fortunate that myself and even Dr. Ramya Setamraju, who is the other co-host, have been able to learn under Sir. And more importantly, what we have learned is not only what to treat, but also what not to treat, that only a person like MS Sir can give you those advice. Thank you so much for accepting and being a part of this, Sir. Now we'll go to the pearls by MS Sir on infectious keratitis.
Good morning. I welcome all of you to this webinar about infective keratitis for general ophthalmologists. All of you know this topic is very important for management, especially in India. Dr. Prasad Bhavankule and Dr. Madhu Uttaraj, both of them asked me to talk about this infective keratitis, particularly for general ophthalmologists, for about 5 minutes. I know I can't justify in 5 minutes, but anyhow, I will go briefly about incidents, predisposing factors, etiological agents, and management. The incidence of corneal ulcers in India, roughly about 1 million per year, all new cases. And if you go by district wise, you get about 2,000 new corneal ulcers every district of 1.5 to 2 million. The incidence is not coming down, it's really going up, not only in rural area, but also in urban area. About predisposing factors, as far as possible in our country, mostly it is corneal injury or corneal abrasion among laborers, farmers, and construction workers, particularly agrarian population. But corneal ulcer due to contact lens as risk factor is not common in India as you see in Western countries, just about 1 to 2%. Regarding causative agents, fortunately for 3 or 4 decades, the agents are almost same in our country, not only in our country, in any country. Both the bacterial and fungal, and parasite is very rare. So among bacteria, you have 2 groups, 1 gram positive, 1 gram negative. Among gram-positive, you see very often staph epi and staph aureus and pneumococcal ulcer. Among gram-negative, we are really concerned about Pseudomonas. Then about fungal, 98% I will say mostly filamentous fungi, either Fusarium or Aspergillus. So there is not much shift or change in causative agents. Then how will you diagnose at your level? That is general ophthalmologist. You have, of course, you have slit lamp and you have a lot of experience. Then a cornea specialist seeing patients almost daily. Most busy general ophthalmologists may see about 1 or 2 cases every day. So how to diagnose a bacterial ulcer is mostly through your experience. Bacterial ulcer, there may be predisposing factor, a risk factor, particularly contact lens, it is usually Pseudomonas. But bacterial ulcer, abrupt onset, very rapid progress with lid edema, chemosis, pain. And if it involves the central cornea, the visual loss will be profound. In fungal ulcer, it is very slow onset. There won't be much lid edema or any inflammation. Clinical picture also, you can, if you use slit lamp, you can easily diagnose or you can guess it is fungal due to its feathery borders, raised dry slough. But in bacterial, it is mostly well-defined circular ulcers and may be associated ocular surface disorders like dry eye or CDK, chronic diagnostics in bacterial ulcers. Fungal ulcers usually involve the healthy cornea. Mostly you see in adults. So corneal ulcers in India mostly you see in adults, people who are doing extra, that is, they are doing outdoor works. About management of corneal ulcers, bacterial ulcers, you have to cover both gram-positive and gram-negative because you don't have facility to diagnose through laboratory methods. Sometimes you may have access, you may refer, but at presentation, within 5 minutes, you have to decide rule out diabetes and diagnostics. Then for bacterial, you start broad spectrum monotherapy, mostly tobramycin or fluoroquinolones. And if you suspect it is pneumococci, then you have to go for ideally cefazolin, but it's not available. Now we use ceftriaxone, but patient tolerance is poor with ceftriaxone. It changes the color. And also you can try 3rd generation or 4th generation fluoroquinolones like 2nd generation ciprofloxacin, levofloxacin, and moxifloxacin, getifloxacin. All these things will cover both staph epi, staph aureus, and also to some extent pneumococci. If you confirm it is pneumococci with diagnostics, if there is discharge and mucocele or pyosil, you have to advise diagnosticectomy in old patient, young patient, DCR. Then go for vancomycin if it is possible. You can formulate 5%, and if you have facility, sterile vials, droplets, all those things, you can go for vancomycin. Concentrated gentamicin is sometimes I feel it's very toxic. Patient tolerance is poor. So use monotherapy every hour, at least first 48 hours. Then according to the response, you can taper to 2 hours, 4 hours, every 4 hours, then use for a week. If you don't see any improvement in 48 hours or 3 days, better to refer the patient to higher centers. Regarding fungal ulcers, so mostly filamentous, the drug of choice is natamycin. That's the only commercially available approved drops. And natamycin good for Fusarium. For Aspergillus, you can get echinocol also. You can use voriconazole also. People are using, but all antifungals mostly they are fungistatic. It takes a lot of time to act, to penetrate. So you have to insist the patient to use constantly for every hour, and there then you see the patient at least every week. Then regarding oral medications for bacterial ulcer, mostly I don't give, but for fungal, if you think patient is not diabetic, is not having any systemic problem, then you can start oral antifungals, but personally I don't use for corneal ulcers. So at the end, you have to explain the patient all the possibility of getting into a corneal scar and unilateral corneal blindness, perforations and therapeutic grafts, regrafts, all these things you have to explain. And good news for you, patients with even severe corneal ulcer, they don't get endophthalmitis, infectious eyes, or pseudophakic eyes. So I hope you got some idea about managing infective keratitis. And I thank you, the organizers, for giving this opportunity. Good day.
Thank you, sir. Thank you, sir.
Thank you so much, sir. And the section 1 winner is Dr. Sahil Agarwal from New Delhi.
Congratulations, Sahil. And you will be expected to join us on the Zoom platform. Yep.
And now we can have Dr. MS, sir, for a few questions, sir.
Go ahead.
Sir, thank you, sir. Thank you for the wonderful talk. Sir.
Madhu, you are not audible. Hello. Hello.
Sir, am I audible now?
Yeah, you are audible.
Yeah.
MS, sir.
Yeah.
Yes.
Yeah.
Sir, a few questions, sir, we had from the audience.
Okay.
Because they are not sure whether it is bacterial or fungal. If they want to put empirical therapy, what would be the drugs of choice?
So you want to cover both?
Yes, yeah, because they are not sure whether it is bacterial or fungal. Sometimes the presentation may not be classical.
So this is mostly, to cover the legal aspect.
Yes, sir.
You have not missed anything, periphery. I think the aminoglycosides like tobramycin, it covers both Staphylococcus and Pseudomonas.
Yes, sir.
To cover fungal, I think natamycin is easily available, and
Yes,
the fusarium is the commonest one. So you can combine both, but there's a controversy.
Yes,
the fungus grows more at the expense of bacteria. If you kill bacteria, fungus will overgrow.
Exactly, sir. Exactly.
If you use more antibiotics, again fungus will overgrow. So, but you are in an unfortunate situation. So there is no harm if you use both tobramycin, one antifungal, or any fluoroquinolones. Cipro was good for Pseudomonas, but now there is a lot of resistance. So you can go for gatifloxin, moxifloxin. Moxi doesn't have preservative, so it is not toxic. There are some reports, when there was epidemic of fungus following contact lens solution in Singapore, they tried moxifloxin, chloromenical. They have found it has helped in 1 or 2 cases of fungal ulcer. So there is no harm in using that. You cover both. Then after a week, then you refer to centers where they have facilities.
Thank you, sir. Thank you so much. And one more question, sir. What are the specific signs that they have to observe carefully and know that they have to refer to higher center?
See, it depends on the type of the patient. Patient, suppose is a farmer, not upper middle class or middle class, difficult to travel, access, distance, where you are there, consultant. So they have to consider all those things. For example, during this COVID period, nobody could get into a cornea consultant or a tertiary care center. So if it is bacterial, 2 to 3 days, if he thinks size is increasing, vision is dropping down, pupil is not dilating, more pain, you just refer immediately. At least you commit, you better go to that whichever center you want to refer. Maybe not too far, not to other states. Within your district or wherever you see a better person, you can refer. For fungal, if you think it is fungus, definitely by clinical picture, you can wait for a week.
Okay, sir.
So if the
Yes, sir.
response is edema goes down, chemosis goes down, panis get white, pupil dilates, no perforation, hypopion level decreasing, then you can consider it is responding. You can try. But patient complains a very severe pain, secondary glaucoma, and they are not happy with the current treatment. Then it's better to refer him.
Thank you, sir. Thank you so much. And the final question, sir, what is your threshold period to do a TPK non-resolving ulcers?
TPK.
Threshold time, sir. How long we can try medications before you do a surgical intervention?
That's a problem. See, one thing is availability of donor cornea, any type, fresh cornea or glycerin preserved, whatever it is. One thing is availability of donor cornea. Then experience of the corneal surgeon who have done therapeutic grafts. And sometimes, see, right now I have a patient from July, okay, aspergillus flavus. He's a 44-year-old man with diabetes, well controlled. He's a pharmacist. So we tried all antifungals on earth. It's not decreasing, it is not increasing, same size of 3-4 millimeter, trace hypopion.
Sir.
We are thinking about doing therapeutic graft, but what is the guarantee after TPK you won't get reinfection? That's the thing.
Sir.
TPK is, I consider TPK for impending perforation, definite perforation, flat chamber. You think contents will pop out like that. That stage only I do TPK. Otherwise, still stroma is infiltrated but thick and no descemetocele like that. Then I wait because TPK, if there is scar, failed graft, I am not concerned. But if you get reinfection, then what will you do next time? That's the thing. So there is no time frame for TPK. Depends on the surgeon skill, availability of donor cornea, and then suppose it flares up, then you should know how to cover it up. Then you should have facility to culture the donor cornea and post cornea, whatever exudate you have. So TPK surgery is, I won't say surgical time is not high, it's not, it's like PKP for optical graft, but post-op, you will have secondary glaucoma, flat chamber, pupillary block, all those things. So you should be ready to cover all those things. But time, fungal ulcers, I will wait 2 to 3 weeks, 4 weeks. But bacterial, now with the current treatment, TPK for bacterial is very rare. Don't do much unless they come late. Once it's perforation, you go ahead immediately.
Yes, sir. Thank you, sir. Thank you so much. Thank you so much for giving your time for us on a Sunday and spending the time with us.
Okay. Thank you. Thank you, Master.
Thank you, Srinivas.
Thank you, sir.
So you're expected to stay with us because the felicitation ceremony, we will be needing you.
Sir. Next section 2, we have Dr. Mamata Singh with us, who will be hosting this section. She is from RIO. She did her D-Ophthal from RIO Chennai and DNB Ophthal from Vadodara, and later she finished her fellowship from Cornea in Refractive Surgery in Ahmedabad, and followed by she was a senior resident at PMCH Patna. She is the scientific committee member of BOS and editorial member of Eastern India Zone Ophthalmological Congress. Ma'am, it's a pleasure to have you with us. Please go ahead.
May I just share my screen?
Yes, ma'am.
Thank you, Dr. Madhu, for those kind words. And I'm really thankful to Dr. Prashant Bhavanpule sir and Dr. Shilpi for this opportunity. And before we move on with the session, I would extend a very warm welcome to Dr. Rupal Sambam, who has just joined this platform. So moving on to this section, as usual, we will be having 5 questions in this particular section. So if you all are set, let's go to question number 1. So the first question for you is, yeah, Tiger Woods underwent which of the following surgical procedure twice? And your options are option A, PRK, option B, smile, option C is intact, and option D is LASIK. And the time starts now. Time's up, and I hope you all made your choices. So the answer for this question is LASIK. Tiger Woods underwent LASIK surgery in the year 1997, following which he won 6 consecutive PGA competitions, and he actually went on record to give part of the credit to this LASIK surgery. But this happiness was short-lived. He started having visual complaints again, for which he underwent repeat LASIK surgery. He was the brand ambassador of the center where he had this LASIK surgery, the TLC Laser Eye Center. And this influenced a lot of youngsters towards this LASIK procedure. But as with any other surgery, LASIK has also got its own share of complication. Gradually, the center got involved in multiple litigation, and it was specifically directed against the surgeon who had operated on Tiger Woods. So the answer was LASIK, and this was one interesting story about Tiger Woods. Of course, there are many others, we all know. So quickly moving on to question number 2. So the question number 2 for you is, the microstria after LASIK surgery involves option A is endothelium, option B is Descemet's membrane, option C is stroma, and option D is epithelial Bowman's membrane complex. And the clock starts ticking now. Time's up again, and the correct answer for this question is epithelial Bowman's membrane complex. The creases or puckers in cornea after LASIK surgery can be of two types, the microstria or the macrostria. And the important reasons for these creases are eye rubbing, trauma, flap redundancy, thin flaps, flap dehydration or excessive hydration, poor flap adherence, or excessive flap manipulation. Microstria are superficial stria. They involve the epithelial Bowman's membrane complex. And these patients are usually asymptomatic, and they are treated only if it is optically significant. They are treated with lubricants, bandage contact lenses, or by lifting, floating, and stretching the flap. Macrostria, on the other hand, they are larger creases. They involve the full thickness of flap, and these patients, they often have visual complaints. If they are detected in first 24 hours, we can try stretching the flap under slit lamp view. But if it doesn't work, we may need to take the patient back into OT. We may need to lift the flap, float it with BSS, and gently stroke it and smooth it back into its own position. But if they remain untreated and undetected for more than 24 hours, gradually the epithelium grows over these grooves. And that is the reason we need to go for deepithelialization followed by floating and stretching. One can put sutures if required, or one may go for PTK. So with this, we will be moving to question number 3. The question number 3 for all of you friends is, all of them are corneal inlays for presbyopia except, and your options are option A, camera inlay, option B is fluid vision implant, option C, raindrop inlay, option D is FlexiView microlens. And the time starts now. Time's up, and the answer for this question is fluid vision implant. So coming to different inlays that we use for presbyopia, the first one is camera inlay. It works on the principle of small aperture optics, increasing the depth of focus. It is a 3.8 millimeter disc with 1.6 millimeter of central opening. It is made up of PVF and placement is pupil-centric in the non-dominant eye. It can provide correction from +1 to +2.5 diopter. The fluid vision implant is actually a type of intraocular lens. It has an accommodative IOL, a shape-changing, fluid-driven IOL implant. Because of the jonular contraction, the fluid movement is from haptics to optics, and this leads to change in shape and accommodation. The raindrop inlay, they are corneal reshaping inlays. They are placed under 130 to 150 micron flap. They increases the central corneal curvature, but there is a very strong safety concern, that is development of corneal haze. The FlexiView micro lenses, they are 3 millimeter diameter, transparent hydrogel-based implant. They alter the corneal index of refraction and they improve near vision by means of bifocal optics. So the answer was fluid vision implant, which is a type of accommodating IOL. Moving on to question number 4. The features differentiating diffuse lamellar keratitis, that is DLK, from infectious keratitis or IK after LASIK are all except. And your options are: DLK usually is visible in first 24 hours, while IK develops after 2 to 3 days of surgery. Option B is flap melt is not a feature of DLK. Option C, in DLK, inflammation typically begins and more intense at periphery, decreasing towards the center, while in RK, it can occur anywhere under the flap. Option D, in DLK, inflammation is confined to the interface, and in IK, inflammation can extend above, below, and around the flap. And the time starts now. So the correct answer for this question is flap melt is not a feature of DLK. Diffuse lamellar keratitis or DLK usually occurs within first 24 hours. It typically begins at flap periphery, decreasing towards the center. It is primarily confined to the interface, and flap melt can occur even after DLK. Infectious keratitis, on the other hand, the usual onset is after 2 to 3 days of surgery. It can occur anywhere under the flap. It can extend above, below, and beyond the flap edge also, and flap melt can occur here also. So flap melt is a feature or that can occur in either of them. So coming to the last question for this section, and that is post-RK patient presenting with hyperopic refractive surprise after cataract surgery. So we have an RK patient who underwent cataract surgery and now he is presenting with hyperopic refractive surprise. So what should be the next step of management? Option A is IOL exchange. Option B, you will wait till the cornea and refraction stabilize. Option C, do the laser refractive correction. And option D, make an arcuate incision on the steep meridian. And the time starts now. So the correct answer for this question is we should wait till the cornea and refraction stabilize. And with this, any patient of refractive surgery who needs cataract surgery now, doing cataract surgery is always a challenge in them. Particularly in RK patient, there is a challenge involving IOL power calculation. The reason being there is a very small effective central zone. These incisions, they create irregularity over both anterior and posterior corneal surface. So ultimately, the decision of true corneal refractive power is also difficult. And there is always a chance of inaccurate estimation of the effective lens position. So what are the methods? There are various methods which have been proposed, like the clinical history method, where we need to have the pre-refractive data of the patient. Hard contact lens method, which ultimately was not found very useful. The ASCRS online post-refractive IOL power calculator, which gives fairly good result apart from other latest gadgets like IOL Master, etc. So if a patient of RK has undergone cataract surgery and is now presenting with refractive surprise, what should be the way? Why it is happening? This causes actually a short-term corneal swelling with flattening and hyperopic shape. So what one should do? We should wait till the cornea and refraction gets stabilized. And usually it takes several weeks to months. So any of the corrective surgery, if you are planning to do, we should wait preferably after 3 months. And this brings us to the end of section 2. And before the core team comes to the result of section 2 winner, it's time to meet one of the legendary figure in the field of ophthalmology, Dr. Virender Singh Sakwan. He's an ophthalmic surgeon of international repute, a teacher par excellent, and an inspiration to thousands of ophthalmologists. He has been actively involved and contributed immensely in the field of translational research in ophthalmology involving limbal stem cells. And he has given the world the technique of SLET, that is simple limbal epithelial transplantation. I don't really have to emphasize the role it is playing or the impact it has created in the overall management protocol of limbal stem cell deficiency. Sir was associated with LVPI Hyderabad from 1998 to 2018 as the Director of Center for Ocular Regeneration and Srujana Center for Innovation. At present, Sir is associated with Dr. Shroff's Charity Eye Hospital, New Delhi, as the Director of Innovations. I welcome you, sir, to this platform. And with your request, I would like to start the video, sir.
Yes, thank you very much.
Thank you, sir.
So you put your video as well on, video info.
All right, I'll give the running commentary.
Yes.
This is a technique, or this is a short video on the technique called simple limbal epithelial transplantation. What you are seeing here in the video is the harvesting of the limbal biopsy. You start dissecting from the conjunctival edge, then you go towards limbus and dissect in the plane of insertion of conjunctiva into the cornea or the limbal epithelium. You don't need to go too deep. Roughly it is about 50 to 60 micron. And then as you are seeing, with a very fine scissors, you cut the limbus at the junction of limbus and conch. And then you take that strip of the limbus, which is pigmented, and towards the cornea. You store this on your surgical trolley in a safe BSS, cover it and tell the nurse not to throw it. Now what you're seeing is the affected eye of total limbal stem cell deficiency of the same patient. And the pannus resection we started from the periphery towards the center. As you're seeing, I'm using a 15 number blade on Bart Parker handle. Why? Because I don't want a very sharp instrument. And you're seeing a iris repositor or such a blunt instrument which is trying to find the plane of insertion of the pannus onto the cornea. And then I'm using sharp scissors to cut the pannus at the limbus and try to clean it. And as you're seeing, the cornea is very nice and clean and transparent. There's no scarring, there's no deep vessels. And then you use the human amniotic membrane, which is preserved, and you peel it off from the nitrocellulose paper. Then you use fibrin glue, which has been prepared earlier by your staff. You use the thick part of the glue first on the cornea, then the second part, and then you bring the membrane, just half of it, and spread it nicely, iron it out all the wrinkles all around, and then excess membrane can be trimmed. And here what you are seeing me making pieces of the limbal segment into smaller explants. You can make 10 to 12 or more. Smaller is better. And it really does not matter the orientation in terms of whether you need to keep the epithelial side up or down, but basically you spread them at an equidistance, 3 millimeter inside the limbus, not at the limbus. And then you can make 2 rows. And when the cornea is such clear, then you are very sure that the outcome of limbal stem cell transplant is going to be very good. So you do not want to put explant in the center of the pupil. You so leave 3 to 4 millimeter of the pupil area clear, no explants. Then You fix them with fibrin glue. Again, very tiny drops of both the component, fibrinogen as well as thrombin. Wait for a minute, and then you put the bandage contact lens. The bandage contact lens will stay at least for 10 to 14 days. And when you are removing the speculum, be very sure that there is no part of the membrane or the glue sticking to the speculum, and then you remove it. Otherwise, you can bring everything off. So this is a very simple, very straightforward procedure. Once you have seen the video, it is not very difficult to replicate this procedure. And this is the most effective treatment for limbal stem cell deficiency. Thank you.
Thank you so much, sir, for this wonderful instruction video. And I will be asking some very basic questions, sir, so that it gets useful for everyone.
Sure.
Sir, what are the clinical features or what are the clinical signs which suggest that a particular patient is suffering from limbal stem cell deficiency?
The diagnosis of limbal stem cell deficiency, purely clinical. The most important reliable sign which you can see is when there is a conjunctiva growing onto the cornea, and along with it drags its vessels. It's not the superficial vascularization or deep vascularization, it's the conjunctiva being dragged onto the cornea. And that happens because the limbal stem cells also act as a molecular barrier for the conjunctival ingrowth. So that's the most reliable. And then there can be secondary features like, recurrent epithelial defects and rough epithelium. All those are secondary features.
So if a patient is having like limbal stem cell deficiency, what should be the next step of management, or what is the management protocol? Is it always surgical, or there is some medical way to come out of this also, sir?
If it is mild and peripheral and not bothering the patient either cosmetically or visually, then no need to intervene. Neither surgery nor medicine.
Okay,
if there is a very fine pannus and just begin and start encroaching upon the pupil, then you can think of some lubricants, topical steroids, and interferon gamma. There are a few reports, especially Minas Cornea from Australia. But if it is a thick pannus, total limbal stem cell deficiency covering the visual axis or causing astigmatism, if it is partial, then only treatment would be surgical, and there is no point trying medical treatment in such cases.
And do you recommend doing this technique of slit even in cases of pterygium?
Yes, there is a technique called mini slit described by a Mexican group after seeing the slit videos, and they have come up with a very simple technique. And then there is a Canadian group who have published about role of slit in recurrent pterygium. So I would strongly recommend, yes, you should combine, and it can be a very small slit.
Thank you so much, sir. Thank you for the wonderful tips. Yeah. And sir, I would request you to stay online so that we can have a little more of interaction at the end of the session, sir. Thank you, sir.
Yeah, sure, my pleasure.
So now it's time to announce the Section 2 winner. And the Section 2 winner is Neha Kumari from Delhi. So it's Delhi again. Congratulations to you, Dr. Neha, and I would request you to get ready. We will be sharing the Zoom link soon. Please come online at the end of the session. We will be felicitating you. At the same time, you will be getting a chance to interact with the legends also, the masters also. And trust me, this is one golden opportunity you shouldn't miss. And don't stop playing. You are the Section 2 winner. There is always a chance you could be the next session winner, earning 5,000, 7,000, etc. So with this, we will be moving on to Section 3. And my co-host is Dr. Ramya Sitamraju. She is a consultant cornea specialist from Vishaka Eye Hospital, Vizag. She has done her MBBS and MS from Andhra Medical College, Visakhapatnam. She has done her fellowship in cornea and microsurgery from Aravind Eye Hospital, Madurai. She is an ex-consultant of cornea, cataract and refractive surgery from Aravind Eye Hospital, Madurai. She is a true cornea person. She looks delicate, she looks fragile, but at the same time, she is really, she has this tenacity, resilience, perseverance, etc. So I welcome you, Dr. Ramya, and handing over the session to you.
Thank you, ma'am. Thank you for that very kind introduction. You have compared me to a cornea, and that feels really great. Yeah, so we'll move over to the section 3. So we'll start right away. So this section also consists of 5 questions. So the first question on your screens. Look at the picture on the right side. A 25-year-old guy presented with pain, redness, and white spot in the left eye for 2 weeks, and he's already on antifungals and antibiotics, but there is no response. What is the diagnosis? So take a look at the picture, think and answer. Your options: A, Fusarium keratitis, B, Aspergillus keratitis, C, bacterial keratitis, or D, Pythium keratitis. And your time starts now. Right, that is the end of our time, and the answer is D, Pythium keratitis. I hope most of you have got it right. So we shall see what this Pythium keratitis is. So this Pythium, which causes keratitis, is an oomycete. That is, it's a fungal-like organism, though it's not a fungus. The cell wall configuration is different between a Pythium and a fungus. And its infiltrates have certain characteristic lesions like tentacle-like extensions, which is shown on the picture on the top right. There are also dot-like lesions or satellite lesions. And there is a reticular or a lacy network-like pattern, which is seen on the bottom right. And there is also a rare presentation, which is a peripheral thinning, which is circled in the picture in the bottom right. And not responding to antifungals is one of the clues which guides us towards the diagnosis. The point to be remembered here is that it might look like a fungal keratitis, but this does not respond to routine antifungal therapy, and that should alert the physician to a Pythium insidiosum keratitis. So it has a very grave prognosis, and from whatever literature is available, the drug of choice is linezolid. So quick look at the differential diagnosis. We had A and B as Fusarium and Aspergillus keratitis are options. Both of them are filamentous fungal infections. As we know, they are characterized by dry-looking infiltrates. There are feathery margins. And when you scrape them for a smear or a culture, you will have a characteristic grating sensation. A hypopyon can be present. And both of them would have responded to your routine topical antifungal. The difference is that Aspergillus, usually A flavors, is much more severe than Fusarium. Then coming to our bacterial keratitis, it is wet looking, it presents with a shorter duration, the pain and redness are much more, and there can be a yellowish or a greenish, usually round infiltrate, depending upon the underlying organism, and it causes much more pain than your fungal keratitis. And the last picture, as we've discussed, is of a Pythium keratitis. So we move to the next question. Again, you have a picture on the right side of your screens. An 8-year-old boy came with a history of pain and redness in his left eye for 2 weeks, and there is a past history of recurrent redness and itching in both eyes. Identify the true statement regarding the clinical picture shown on the right side. Your options: A, this condition is a very common manifestation of the underlying disease. B, it is caused by Staphylococcus aureus. C, topical steroid is indicated. Or D, the drug of choice is a combination of antifungals and antibiotics. So think carefully and answer, and your time starts now. That was the end of your time, and the answer is C, topical steroids are indicated. So the picture we see is that of a shield ulcer, and topical steroid is the drug of choice. We shall see why. So this VKC is usually a disease of young boys. Usually it presents with papillae and congestion and Horner Tranter spots, but the first sign of corneal involvement is a superficial punctate keratopathy or an epitheliopathy. These can slowly grow over time to form a shield ulcer or an epithelial defect. And these shield ulcers in VKC range from about 3 to 20%, which is not very common. That's why our option A was wrong. They are characteristically present at the junction between the superior and the middle thirds of cornea, that is the place where the eyelid rubs the cornea, and they are oval. And it is not a bacterial ulcer, it is a sterile ulcer due to the inflammation. Hence, it is not caused by Staphylococcus aureus and it doesn't respond to antimicrobials. So in our case, the young boy had a recurrent redness and itching, which goes in favor of a vernal keratoconjunctivitis. The age of the patient and the gender all point towards a diagnosis of VKC. And the shield ulcer, because of its typical location with other signs and symptoms of allergy. And this is one of the very few conditions wherein topical steroids are indicated in the case where an epithelial defect is present. So with this, our question 2 was over. Then we move over to our question 3. Again, take a look at the picture. It's a very classical picture, and identify the true statement regarding the clinical condition depicted in the picture on the right. Your options: A, the causative organism is a fungus. B, the drug of choice is moxifloxacin. C, microscopy reveals double-walled cysts. Or D, the drug of choice is amikacin. And your time starts now. Time is up. I hope most of you have responded correctly. This is a classical picture of a nocardia keratitis, and the answer is the drug of choice is amikacin, D. So if you look carefully at the picture, there are multiple pinhead-like lesions which form a wreath-like configuration. The wreath is a garland that is usually presented at funerals. So that is the configuration that is described in case of a nocardia keratitis. So these nocardia are gram-positive beaded filamentous bacteria, hence they are not fungi, and they are weakly acid-fast as well. So if you look at the pictures on the right, the first picture on the right that is on the top shows the weakly gram-positive beaded filamentous bacteria, and on the bottom you can see weakly acid-fast bacilli that is with 1% H2SO4 staining. And the ulcers, as I said, have pinhead-like and wreath-like configurations, and the drug of choice is amikacin, hence not moxifloxacin. And double-walled cysts are characteristic of acanthamoebae and not of nocardiae. So this nocardia keratitis and fungal keratitis can look similar sometimes. As I said, there are certain characteristic features like your wreath-like pattern and also superficial granular pattern, which form the differentiating feature of nocardia keratitis. And in case you do a scraping and microscopy, you will know the diagnosis. Then coming to your next question, again another classical picture is seen on your screens. Identify the correct statement regarding the clinical picture that is shown. Your options: A, it is peripheral ulcerative keratitis. B, it is staphylococcal marginal keratitis. C, it occurs due to a hypersensitivity to streptococcal antigen. Or D, the clear interval is absent. And your time starts now. Right, the time is up, and here's your answer. It is staphylococcal marginal keratitis. Here you see multiple infiltrates. They are peripheral. They are separated from the limbus by a clear interval, and the exact typical locations all point in favor of a staphylococcal marginal keratitis. We are going to see what it is. This staphylococcal marginal keratitis is an inflammatory disease of the peripheral cornea. The infiltrates are typically seen in the points of intersection between the eyelids and the limbus, that is at 2, 4, 8, and 10 o'clock positions. And the inflammatory response is believed to be due to the staphylococcus antigens, hence not streptococcal antigens as one of our options was. And this condition is usually associated with lid margin disease as in staphylococcal blepharitis. And topical steroids are the mainstay of treatment, and we also have to address the lid margin disease or blepharitis. A quick look at the differential diagnosis. Your peripheral ulcerative keratitis or Moran's ulcer would look similar. Both of them have an epithelial defect and an associated stromal infiltrate. There is no clear interval between the limbus and the peripheral ulcerative keratitis. And this PUK is characterized by a systemic illness. So when you investigate, you find out that there is some systemic illness leading to the peripheral ulcerative keratitis, whereas in the Moran's ulcer, there is no systemic illness. And if you see, there is associated scleritis, episcleritis, and conjunctival inflammation in the case of PUK, whereas in Moran's ulcer, there is no associated scleritis. So those two were the main differential diagnosis. You can have a bacterial keratitis in the periphery, though it's usually described as central. Rarely, if there's a trauma in the periphery, you can have a bacterial keratitis, which is usually single. There's a large epithelial defect. It could look irregular and it is progressive. So that is what differentiates a bacterial keratitis. A clear interval may or may not be present depending upon where the trauma had occurred. Similarly, in case of an herpetic stromal keratitis, usually you find single lesions and they are associated with epithelial defects and corneal hypoesthesia. So this is how you differentiate the various other lesions. Your question 5, again, all eyes on your screens, all fingers on your keypads. Look at the picture on the right. Causes of this condition could be all the following except. Remember, this is all except. Your options: A, drug toxicity; B, early fungal keratitis; C, a healing epithelial defect; and D, herpes simplex keratitis. And your time starts now. Your time is up, and the answer to this question is D, herpes simplex keratitis. So this will be a little surprising because it does look like a dendrite, but it could be all except a herpes simplex dendrite. So we'll see why it is so. So the dendritic lesion caused by a herpes simplex keratitis is usually referred to as the true dendrite, wherein you have dichotomous branching and terminal end knob configuration. So if you look at the tips of the branches, they seem to be a little enlarged, or you see a knob-like configuration, and it is usually central, though you can see a lot of peripheral dendrites as well. Whereas pseudodendrites are the term used to describe certain lesions which resemble a herpes simplex keratitis but are not actually a herpes simplex epithelial lesion. So these do not have any terminal knobs or dichotomous branching, so that is how you differentiate them. And the lesion can be distributed anywhere on the cornea. So examples of this are an early fungal keratitis, drug toxicity due to anti-glaucoma medications, any other medication containing the BAK, or prolonged use of antibiotics also can lead to a drug toxicity. Your healing epithelial defect can give rise to a pattern of a pseudodendrite where the epithelium meets each other, or the surfaces meet each other. A corneal abrasion or a very early acanthamoeba keratitis and a herpes zoster keratitis also can look like a pseudodendrite. So if you look at this picture, the first picture on the upper left is that of a healing epithelium. It might look like a dendrite, but if you look carefully, there is no dichotomous branching or end bulb-like configuration. Similarly, on the upper right, you see HZV keratitis, where there is no characteristic dendritic pattern where you see a dichotomous branching. In the bottom left, you see early fungal keratitis, where there's an actual infiltrate and not just an epithelial lesion. And you find an irregular dendrite-like configuration. And the last picture is that of a corneal abrasion, which might look like a pseudodendrite or a dendrite. That's why it's called a pseudodendrite. So with this, our section is over. So at this juncture, it's my pleasure to introduce our team to you. Rome was not built in a day, so wasn't our Brain Teasers quiz team. There are a lot of efforts. There have been efforts of people from all over the country. It's truly a pan-Indian effort. And we'd like to thank our team leader who's leading right from the front, Dr. Prashant Bobonkule. Thank you very much, sir. Now I'd like to present this short video to you all. Right. Thank you, sir. Thank you for making this such a wonderful learning experience for all of us and also for our participants. And this would not have been possible without our sponsors, Entod Pharma. I'd like to thank them on behalf of our team of Brain Teasers. I'd like to play a short video here. Right. So time to announce our next session. As ever, we are getting better and better. So it's the first Sunday of next month, that is 1st of November 2020 at the same time, 4 p.m. And we are trying to improve and we are getting better. So any feedback is most welcome. Please write to us at the email ID or the WhatsApp numbers provided below. Time to announce our section 3 winner. Our winner is Dr. Kabita. Dr. Kabita is from Delhi. So please, Dr. Kabita, please keep playing. You might be the full winner of the entire quiz as well. You will also be given an ID to log in at the end of the session. Right now, I take the pleasure to introduce my co-host, Dr. Palak Kusumgar, who is from Nagpur. So she's done her fellowship in cornea and refractive surgery from Narayan Netralaya and is currently practicing as a cornea and refractive surgery. This is a very modest introduction. We have also heard that she runs COVID centers. So all of us need to be good towards her. That is what we've heard about her previously. So right, I hand this over to Dr. Palak.
Thank you, Dr. Ramya, for that kind introduction. So let us move on to the next section. As we have already completed more than half of the quiz, it is now time for all of you to buck up. And you still have got chance to win another 2 sections and be the overall winner. So the first question of the section 4 is, which of the following is true about the lesion shown in the figure? Option A, it is always benign. Option B, it is contagious and easily spreads to others. Option C, it affects only superficial epithelium. And option D, it can produce keratin. And your time starts now. So your time's up. The answer for this question is option D, that it can produce keratin. So this figure basically shows a squamous cell carcinoma, which is non-contagious and does not spread to others. It can invade cornea without conjunctival involvement, and limbus involvement is usually rare. It can also invade other intraocular structures, and several appearances have been described like gelatinous, leukoplakic, or papilliform. Histologically, it is epidermoid and spindle-shaped cells that replace the normal conjunctival epithelium, and it produces a whitish keratin plaque, which is shown in this histological slide. Treatment is usually local excision with white margins with cryotherapy, and local radiotherapy can be used after excision. Coming to the next question of this section. Patients with ocular cicatricial pemphigoid, which of the following is true regarding this condition? Option A, it has immunoglobulins bound to conjunctival basement membrane. Option B, may have increased number of goblet cells. Option C, it can benefit from limbal stem cell transplants. And option D, it frequently presents with keratitis. And your time starts now. And the time's up. The answer is it can have immunoglobulins bound to conjunctival basement membrane. So ocular cicatricial pemphigoid is a chronic disease which mainly affects the mucosal surface. It is typically seen in elderly population, bilateral, and it is presented asymmetrically. It is associated with chronic conjunctivitis, which leads to subconjunctival fibrosis and a reduction in goblet cells. Immunofluorescence staining shows immunoglobulins at the level of basement membrane. Treatment is usually with systemic immunomodulators, and it helps with cultivated oral mucosal epithelial transplantation. Scleritis is not a feature of OCP. Several stages of OCP described are stage 1, when there is subconjunctival fibrosis, stage 2, which shows fornical shortening, stage 3 is formation of symblepharon, and stage 4 is complete keratinization of the ocular surface. Now coming to the next question of this section. Question 3. The patient presents with complaints of worm-like mass in her eye. The most appropriate action for this patient would be option A, excisional biopsy. Option B, helminthic workup. Option C, grasping the lesion with forceps and using cryotherapy. And option D, reassurance and observation. And your time starts now. So the time ends. The answer for this question is option D, reassurance, and observation. So this patient has a normal finding of lymph vessel in her eye. And this condition usually does not require any treatment, and reassurance is enough. In cases of filariasis, where the active or live worm can be seen subconjunctively, needs a systemic helminthic workup. As you can see, several pictures shown over here, where the microfilaria is seen in the blood and eye picture is something like as shown in the picture. This condition needs removal. Now coming to the next question, question 4. Which one of the following statement is true regarding the image shown in this figure? Option A, microscopic examination without cellular atypia would confirm the benign nature of this lesion. Option B, growth and increased pigmentation can occur during puberty. Option C, lesion is confined to conjunctiva and does not affect underlying sclera. Option D, treatment with cyclosporin drops is needed since steroids are ineffective. And the time for this question starts now. Coming to the answer of this question, it is the lesion is confined to conjunctiva and does not affect the underlying sclera. So this picture shows a benign conjunctival lesion. The symptoms with usually patient presents with such lesions is irritation, pain, discharge, epiphora, photophobia, or foreign body-like sensation. The clinical signs which should be looked at while examining these lesions can be stated in ABCDEF pattern. That is, looking at the asymmetry of the lesion, looking at the borders, the color variation, the diameter of the lesion, and how the lesion has evolved over time. The other features which should be looked at are the dilated feeder vessels to the lesion, any evidence of surface keratinization, and transformation of the surrounding tissue. Various differential diagnoses of these lesions could be, it could be a papillary or follicular conjunctivitis, or ocular surface squamous neoplasia, or it could be a cystic benign melanosis of conjunctiva, or a primary acquired melanosis of conjunctiva. So looking at the various differential diagnoses, including nevus melanosis, ocular melanocytosis, PAM, that is primary acquired melanosis, a malignant melanoma, or conjunctival lymphoma. Out of these, PAM, malignant melanoma, and conjunctival lymphoma have history of progression and have metastatic potential, and also are non-benign. So these lesions should not be missed and be treated carefully. Now coming to the next question, that is the last question of this session. Which tear layer contains immunoglobulin A? The options are option A, mucin layer, option B, lipid layer, option C, aqueous layer, and option D, glycoprotein layer. And your time starts now. The answer to this question is aqueous layer. So aqueous layer contains IgA, and it is secreted into lumen of main and accessory lacrimal glands, and it plays a role in host defense mechanism. So the various layer of tear are lipid layer, aqueous layer, and the mucus layer. Lipid layer is produced by meibomian gland and accessory lacrimal gland. Aqueous layer is produced by lacrimal gland and accessory lacrimal gland, and mucus layer comes from goblet cells in conjunctiva and corneal epithelium. The physiological function of lipid layer is mainly to prevent the evaporation and stabilization of the tear film. The role of aqueous layer is lubrication, antimicrobial property, and it provides oxygen and nutrition to the underlying surface and the eye. And the mucus layer lowers the surface tension and stabilizes the aqueous layer. Deficiency of any of these layers results into dry eye. Dry eye can be basically divided into two types, that is aqueous deficiency and evaporative. Aqueous deficiency includes Sjogren's and non-Sjogren's dry eye. And evaporative dry eye could be extrinsic or intrinsic. Intrinsic is mainly due to meibomian gland deficiency or low blink rate or due to any drugs, while extrinsic could be due to vitamin A deficiency, any use of drugs which has preservatives, chronic contact lens wearers, or in allergy cases. This brings us to the end of this session. It gives me immense pleasure to invite next guest of this session is Dr. Rupal Shah. She is one of the pioneers of laser refractive surgery, and she started practicing these surgeries way back in 1994. She is Group Medical Director of New Vision Laser Center for Sight, and a part of Asia's largest chain of laser refractive clinics. She is very famously known Smile Woman. Initially, even I thought she is known as Smile Woman because of her beautiful smile, but that's not it. She's the first lady to perform single incision relaxed smile when the surgery had just come into vogue. She has several publications in prestigious peer-reviewed journals. It's a pleasure to invite you, ma'am. Let us have pearls from her.
Hi, let me share some pearls to avoid pitfalls in laser refractive surgery. The first pearl is to refract well. All good LASIK surgeons should know good refraction. The second is to choose your patient well. You should avoid every patient who asks questions too much or somebody who comes to a decision too fast, somebody who has undergone a previous failed refractive surgery, and people who are very demanding. It's also very important to get a good teacher. Recognize that there is a learning curve. It can also be tackled by watching experienced surgeons who use your brand of femto laser, microkeratom, and excimer laser. Have an experienced doctor stand by if possible. And initially, try to select patients with low expectations. It's a good idea to know your machines because unless you know the eccentricities of your machine, you would not know how to use them well and get good results. It's important to ensure appropriate flap diameter to get a good stomal bed exposed. Otherwise, your refractive results will not be optimal. You should standardize your technique. Don't keep changing your technique and your steps too often. Do a change of one step at a time. Otherwise, you would not.
I'm sorry for that. Let me go back.
Hi.
Move a bit. Shall I put it on?
Yes.
You can forward it.
Somebody who has undergone a previous failed refractive surgery, and people who are very demanding. It's also very important to get a good teacher. Recognize that there is a learning curve. It can also be tackled by watching experienced surgeons who use your brand of femto laser, microkeratom, and excimer laser. Have an experienced doctor stand by if possible. And initially, try to select patients with low expectations. It's a good idea to know your machines because unless you know the eccentricities of your machine, you would not know how to use them well and get good results. It's important to ensure appropriate flap diameter to get a good stomal bed exposed. Otherwise, your refractive results will not be optimal. You should standardize your technique. Don't keep changing your technique and your steps too often. Do a change of one step at a time. Otherwise, you would not be able to build your nomogram. And it's always good to have your own nomogram set up once you have 25 to 30 patients done. Pearl 7 is not to be in a hurry. Take time to do those important steps well and make sure that you are following all the steps properly, one after the other, because haste here is definitely a waste. Do not ablate on the hinge, whatever happens, because this is going to cause an irregular astigmatism, which no amount of topo linking will also be able to serve. Make sure that you make the necessary changes if your hinge comes too closer. Strictly adhere to the law of thicknesses. Don't try to bypass any known things that we already have learned from our past experiences. Leave at least 280 to 300 microns on the stromal bed. Limit your treatments to what your cornea can afford to bear. Also make sure that you are using the other techniques that are also available whenever indicated. When in doubt, it's a good idea to wait and reevaluate this patient after 6 months rather than taking chances. Minimally handle the flap. Don't try to squeeze the flap excessively. Do not clean the flap very aggressively. And use a very light sponge to absorb the water from the flap to bed gutter. You make sure that you're floating the flap back on a bed of BSS, and that will also make your things very simple. Whatever happens, maintain your poise, because LASIK complications can be quite forgiving if handled well. In case you can't handle them well, abandon, leave it as it is in as much of anatomical alignment as possible, and you should refer the patient to an expert who can actually manage it well. It's a good practice to maintain good sterility, even though inherently some aspects of the procedures are unsterile, but there is no substitute for taking good care about sterility. See the patient within the first hour and especially within the first 24 hours, because if there is anything that's going to go wrong, like DLK, infection, or a flap displacement, it's more likely to occur within the first 24 hours. And if you handle them earlier, the refractive results as well as the safety of the cornea will not get compromised. And the final pearl, refractive surgery is about care, more care, and even more care. And I will leave you with this quote by Mahatma Gandhi, that you should live as if you're going to die tomorrow, but you should learn as if you're going to live forever. Thank you.
Thank you, Rupal madam. That was a great pearls for all the beginners as well as the people who are into practice, refractive practice. Yeah,
Thank you,
you can come live on the platform.
Thank you so much. Thank you so much, ma'am, for those kind tips. You have given very minute tips also for all the general practitioners to practice refractive surgery. Ma'am, one question which majority of the people in the audience wants to know: if you get a patient who is ready to get done all the 3 types of surgery, whatever you advise, what surgery would you prefer? PRK, SMILE, or LASIK? When cost is not the issue, your choice of surgery.
Okay, so here we are talking about an ideal patient with no ifs or buts in the cornea. And you know that this is a good candidate, right?
Right.
For me, my baby is SMILE. So if there is no cost relevance, I do like to take up SMILE because it combines the best of both worlds. It's like doing a PRK without the pain and doing a LASIK without a flap. So it has the advantage of both the procedures combined together. So that is usually my first choice. But I also give all the options to the patients, making them understand the pros and cons of each. If I'm looking at more in terms of safety, and if the number is small, PRK is going to be the first choice. If I'm looking for a quick recovery, then LASIK or SMILE is going to be my choice. And I do respect the patient's judgment because they do come from a background, and if they ask for a particular procedure to be done, I do that if it is feasible, because it's ultimately the patient who is going to be happy or unhappy, depending upon what you do for them. So if it is in their mind that they are going to be happy with one procedure over the other, if it is possible, it's better to do the procedure of their choice.
Right, ma'am. Ma'am, next question is, usually we talk about what is the maximum refractive correction that you can do on a corneal surface. Ma'am, what the audience wants to know is, what is the lowest that you have corrected on the corneal surface? Or you would go in for a refractive surgery, the lowest refractive error?
So the lowest that I have treated is -0.5 with 0.25 cylinder, and this was in a patient who was in the US military, and he insisted me to do this. Normally, if the patient has 6/9 or better vision in both the eyes, I don't like to do a refractive surgery because they are not dependent on their glasses, and the predictability of the procedure is plus or minus 0.5 diopter. Here he said it was a question of whether he shoots first or his enemy, and he preferred to be the first person to shoot, so I helped him out. In general, two things need to be taken care of. One is, of course, the corneal pachymetry when you're talking about the higher corrections. But that's not all, because corneal pachymetry is not the only deciding factor. What you ought to see also is the moldability of the cornea. And cornea usually likes to remain within the physiological limits of flatness as well as steepness. So to try and steepen the cornea too much beyond 50 diopters, or if your endpoint in a flatter cornea is going to be flatter than 36, 37 diopters, then you should expect that this particular cornea is not going to remain stable with its result, and it will regress. So that is going to be also a determining factor of how high I would want to treat. Also, beyond 10 diopters, you would find that you may have to reduce the zone size, and also the amount of ablation and the changes in the corneal surface would lead to higher amount of aberrations that are induced and the tear film instability. So it is preferred to be treating lesser number of errors on the cornea. And now we have this excellent option of giving, putting in ICLs, or if it is beyond presbyopic age group, doing a clear lens exchange. So that would be my choice.
Thank you. Ma'am, one last question which I would take is, what is your selection criteria? As you said, the residual stromal bed should not be less than 280 or 270. So ma'am, while deciding on the refractive surgery, do you look at the residual stromal bed or other parameters like percentage tissue ablation or other factors?
So I try to look at everything, especially if I'm treating very high myopia. I try to follow the Rendelmans as well as the PTA, as well as leaving behind enough tissue, because, and looking at the final outcome, because I think each of those things are like pearls in themselves. And if you can incorporate all the understanding that is there, you would be able to avoid many complications. So I calculate the PTA for each and every patient, and accordingly try and either reduce the zone or leave behind some power if we are treating a high myopia.
Thank you, ma'am. I hope those pearls were useful to all the general ophthalmologists as well, and they would be more confident performing surgeries next time.
Well, can I take this advantage of really thanking all of you who are involved in organizing this? I think it's a wonderful organization, and I'm really honored to be here. I think you guys are doing a great job. I think we should keep it
Thank
up.
you, madam. You need to stay back. We have some more questions beyond ophthalmology for you after the end of section.
I don't want to leave. I couldn't leave. I was glued to my seat.
Thank you, ma'am. Thank you. Please stay with us. Yeah, Palak, go ahead.
Now let us go to the most awaited part of end of the session, that is announcing the winner of this section. The winner is Dr. Gaurav Mujumdar from Kolkata, West Bengal. Finally, a winner who is not from Delhi. I would request Dr. Gaurav Mujumdar, you will be getting the link to come on the Zoom platform at the end of this quiz. Now, moving on to the next section, I would like to welcome Dr. Madhu again for the next section.
Thank you, Palak. So welcome back to the last session of this brain. We'll straight away go to the questions now. Question 1. Which Indian-born scientist had a key role in the development of LASIK? Your options are A. Kumaran Iyer, B. Jaswinder Randwa, C. Rangaswamy Srinivasan, D. Premnath Basu. And your time starts now. And the correct answer is Rangaswamy Srinivasan. Rangaswamy Srinivasan is a Madras-born scientist who had a 30-year career at IBM Research. He was very instrumental in developing the technique for ablative photo decompensation and contributed to the development of LASIK eye surgery. He also received the coveted National Medal of Technology in 2013 from President Obama. So let us go to the next question. Progression of refractive effect is seen after which refractive procedure? The options are LASIK for myopia less than 3 diopters, option B, radial keratotomy, option C, conductive keratoplasty, option D, LASIK for hyperopia of more than 3 diopters. And your time starts now. And the correct answer is RK, which is no longer relevant and has become obsolete. So if you see, almost after radial keratotomy, there is 1 diopter of progressive hyperopia in at least 43% of the patients. And this can be from 4 months post-op to 10 years post-op. Other surgeries, however, are stable or may show regression, but may not show progression. The question 3. Which of the following steps is critical when implanting a phakic IOL? Option A, rotate the lens 90 degrees. Generous amount of visco should be used. Option B. Option C, minimal rotation of the implant should be done. Option D, leave very small amounts of visco to prevent pupillary block. And your time starts now. And the correct answer is C, minimal rotation of the implant should be done, because the lesser you rotate the implant, you'll avoid pigment dispersion into the anterior chamber and have lesser complications. Visco should be used optimally. It should not be used too much or too less. If you use too much, you can cause a iris prolapse. Let's go to the next step. Next question, question 4. Peripheral corneal relaxing incisions are contraindicated in which patients? Option A, history of penetrating keratoplasty. Option B, Terrien's marginal degeneration. Option C, arcus senilis. Option D, in pseudophakic eyes. And your time starts now. And the correct answer is Terrien's marginal degeneration. So peripheral corneal relaxing incisions should be avoided in any corneal thinning disorders, as they have an increased risk of corneal perforation and unpredictable refractive results. Let us go to the last question of this section. Which of the following is not true about monovision? Option A refers to the use of one eye for distant vision and other for near. Option B is mainly reserved for presbyopic patients. Option C requires one eye to be made hypermetropic and the other eye to be made myopic. Option C reduces visual acuity and stereopsis. And your time starts now. And the correct answer is we need not require to make one eye hypermetropic and make the other eye myopic. All the others are true. So monovision or blended vision is a concept in which usually the dominant eye is corrected for distance vision and the other eye is left nearsighted. The options are contact lens, glasses, refractive surgery, and IOLs also. However, the monovision or blended vision can be successful only from 60 to 70% of the patients. So they're not suited for all. And as I've already seen in the options, the compromises of monovision are poorer depth perception. There would be some visual strain. There can be blurred vision at night, especially while driving, and difficulty seeing intermediate distances, and they need to wear glasses for intense close-up work. So that finishes the section 5 and the last question of our quiz. So please follow us on Facebook and YouTube if you have missed our previous episodes, and you have a lot of interesting trivia and pearls from experts like legends in their particular fields in all the specialties of ophthalmology. So let us now chat with the experts before we announce the section 5 winner and the overall winners of this section. Now I welcome all the 3 guests to start. If Dr. Srinivasan sir is there.
Yeah.
Yes,
Sir,
sir.
I think this section is mainly for non-clinical questions.
Yeah, but I think it is for everyone.
Yes,
Even
yes, sir.
was learning.
Yes, sir. Sir.
For everyone.
Now this section is more of fun section, sir. We'll not be asking you any clinical questions. So what would be your top non-clinical advice to the young ophthalmologists out there?
Young ophthalmologists?
Non-clinical advice, sir.
Non-clinical advice, okay. I think you need patience. Don't rush to make money immediately. Money will come. You do your job, constantly quality work, and don't copy others. Learn from your seniors and mentors, and definitely you'll have comfortable life. And don't rush.
True, sir. True. Very true. And
one question from me for you, Srinivasan sir. You are now as chief cornea surgeon. You are also CEO of one of the biggest, largest eye care system, that is Arvind Eye Care System. Doesn't this administrative work come in the way of your love, that is primarily cornea? And how do you balance it?
Definitely, I was fortunate. We have admins, they take care of their job. We take care of only patients. So only thing is we involve not in finance and all those things. We involved in hiring people, postgraduate fellows and staff. And also when you buy equipment, and we put our inputs. and regarding finance and day-to-day activities, you have an admin. They're not a great person like CEO, but somebody to take care, power supply, generators, getting diesel, checking vehicles, all these things you should not go.
So hats off to your humility. I really don't understand what you eat. People eat that you are so humble down to the earth in spite of being the CEO of the Arvind Eye Care, sir. We salute you people.
Sir, one more question to MS sir. Sir, what is that you love apart from Cornea and Vijay madam?
So I see, basically I'm from village, and basically traditionally we are farmers. So live farming now, after my like I'm retired from admin and all those things, but I'm not retired from seeing patients. But so now I enjoy farming, and I have developed a non-fertile area into a farm, and even today morning I went to the farm. Every Sunday I go, I enjoy, and you don't make money, you lose money, but you have peace of mind. So
Yes, sir. Very true, sir. And regarding his working and seeing patients, I just want to add one thing. Even today, if you send him a picture of a corneal ulcer or any question before 3 p.m., he usually checks his mail around 2 p.m. or 2:30. You'll get the reply sharp the same day by 3 p.m. So if you have any doubt, I ask the patient to wait, send across the mail to MS sir, and ask the patient to come back by 2:30 through. I have an expert opinion by then. So kind of him to respond to opinions over email also. Thank you, sir.
So now it's time for Dr. Virendra Sangwan there.
Actually, I have a similar question for Dr. Sangwan sir also. What is his non-ophthalmic interest? We have heard a lot like about your zeal for fitness and everything, sir.
Yes, I have lots of other interests other than ophthalmology and cornea. And one being you just now said about fitness. I run, do exercise. I run almost 10 to 15 kilometers every day. I was enrolled in an online competition called 100 Days of Running, which is today was the last day. So I have finished fifth in Gurgaon and clocked 1,550 kilometers in 100 days. That's one. Number two, I try to understand the human beings, how they work, how they interact, how their psychology works, and in that process, try to understand the financial markets, how the stock market works, how the business works, and then I'm very passionate about technology, how technology can help society, the medicine, and everything else. Many other interests I have.
Sir, if I'm not wrong, you had two loves in ophthalmology. One was uvea and the other was cornea. Why is it that you dished upon your uvea love?
नहीं वो नहीं किया मैंने अभी भी करता हूँ. Only thing is that I see you have a limited amount of time, so you have to prioritize. But I have not tested uveitis. I see patients, I participate in clinical trials, and I do everything what I was doing. Yes, what I have not done and what I don't believe is like, uveitis society I started, but I don't cling to it. I feel that I have young colleagues who are taking care of it. I need to move on. Similarly, I disrupted myself when I was at peak in LVP. I moved out and started all over again. So I think it's just the pattern of my personality. I have not dissed anything.
Thank you, sir. Thank you.
Actually, I have one more question, sir. It's something between ophthal and non-ophthal. See, it's very often said that India is not the place for original research. There are very few centers available for a person who actually wants to go in this field. So if a person is actually interested in this research, then how to chart out the entire journey, as in how to approach the career?
I think there is a little bit of misunderstanding about research and the belief that research can happen only in the big centers or only in centers where you have everything well equipped. I don't think that's true. Any good clinician having a decent practice. Anywhere in the country can do clinical research, can do operational research. Most of you believe that research means that you have to be a basic scientist to doing genetic research or, pure molecular research. I think that's only one aspect of this is research. All the clinician, they can do clinical research, they can participate in clinical trials, they can write excellent case reports, articles. So it's a question of thinking creatively and think about what you are seeing most often. See, for me, if you see, I focus on chemical burns because that's what I was seeing in LVP and nobody else was doing anything. So I focus only thing which I was seeing: Steven Johnson, OCP, ocular allergy, and chemical burns.
So we just need to find out a way, whatever we have with us.
Yeah, whatever you are seeing in your practice and how to solve their problem.
Yes.
And with next coming to Rupal ma'am, let us follow the trend. Ma'am, what are your non-ophthalmic interests?
Okay, so I have a lot of non-ophthalmic interests. And in fact, my message to the younger ophthalmologists is also to not to take yourself too seriously. I think you should do a work-life balance, because ophthalm is definitely a major part of your life, but that cannot be your only life. So I'm interested in dancing. I have choreographed dances. I have learned Bharatanatyam. I still dance, and I learn dancing still. I love to read. So I read all sorts of books, fictions, non-fictions. I love to exercise. I love to talk to people. I love to know people. I did a few courses taking advantage of this lockdown period in psychology to understand how you can better understand other people. And of course, I love to argue with my husband, which I don't always win, but I do love to do that.
Full madam, मुझे डांस सिखाओ आप. मुझे सीखना है.
My husband, I can make him dance on my
husband को तो सब डांस करवाते हैं ना.
But I agree with you, Dr. Sangwan, that it is not only required to have a laboratory or something to do your research. We had our small commercial practice, and yet we could help in the evaluation of the smile procedure. There were only 250 eyes done in the world, and we did the next 1,000, and we also could suggest changes which can make it into a viable procedure to be released world over. So it is not just the infrastructure which matters. I think it's the passion and your involvement which can help you participate in research and clinical trials.
I think Shilpi has a question for you. Dr. Shilpi.
Ma'am, you manage 2 cities, Vadodara and Mumbai. And for a female, the capital city, that is family. So how do you juggle between these 3 cities?
So I think there should be a will to extend yourself, and then it's not so difficult. My husband and I could set up 22 centers across India with very little finance to begin with, and taken loans and everything. And we were in this together. I've often carried my children with me when I go for practices. And I have really a good support system. So my husband is my backbone. My in-laws, we stay with our in-laws still. And I must say that my children are the most understanding and the best children in the world. But you do have to be prepared for a little extension of yourself. You cannot allow yourself to get tired or give up easily. And you should be passionate about what you're doing. So unless you like what you do, I don't think you'll be able to do things beyond your capacity.
Ma'am, rightly said. Sir, one thing I would like to tell about Rupal ma'am, wherever you meet her, however dull you are feeling in the day, if you see ma'am, you are refreshing, because she has got such a beautiful smile, and that smile never goes off her face at any conference or any meet, at any hour of the day you meet her.
Yeah,
Well, I'm really blessed because I have so many reasons to smile. So no.
Not just the cornea.
Okay. So we come to the end of the chat session. Now we are ready with the winner and the section 5 winner today. Can you have the next screen, please? Okay. Sai, can we have your screen share? Yeah, the section 5 winner is Dr. Akshata Prakash from Bangalore.
The only one from South India today.
Today, one only.
Angwan sir has shifted to Delhi.
Yes.
And the first runner-up today is Dr. Anand Singh Brar, again from Delhi. And the winner today is Dr. Kavita, again from Delhi.
तो दिल्ली भी इंडिया में ही है, देख लो आप.
All good people are moving to Delhi.
So I request all the winners to join us on the Zoom platform. You have an opportunity to interact with all the greats in Cornea, Dr. Rupal, Dr. MS sir, Dr. Virendra sir. So Mr. Sai, have these people joined? The winners have joined us?
They are still joining, doctor.
They're still joining. So, okay.
Sahil has joined. Akshata has joined.
Okay. So I think we can start with our felicitation and interaction ceremony. Sahil, are you there? I don't see you. Please put on your video input as well as audio input on. So the section 1 winner today is Dr. Sahil Agrawal and Dr. Madhu. You are supposed to felicitate him with an Amazon gift voucher of 1,500 rupees and also interact with him.
Congratulations, Sahil.
Sahil, we need to see you. Please put on your video.
Video and audio is both of Sahil's.
Sahil, can you hear us?
Yes, sir. Yeah, doctor. I am sharing the screen now.
Yeah, please.
Yeah, Sahil is now online, audio and video both.
Yeah. So Madhu, your turn to felicitate him and interact with him. Young guy.
Congratulations, Sahil.
Thank you so much, sir.
Congratulations. Wonderful performance. So where are you from?
So for the last 7 years, I've been residing in Delhi. So
Okay.
right now I'm from Delhi. So I'm in AIMS. I'm working as a senior resident in the Department of Oculoplasty, sir.
Wonderful. So being in oculoplasty, you won the Cornea quiz. Eh?
So, I couldn't answer the rest of 4 of the rounds, but the first one was relatively easier.
Yeah. Congratulations once again, and stay back till the last. Thank you.
So your gift voucher, please. Sai, you need to give the gift voucher to Mr. Sahil.
Yes, sir. The gift voucher for the section 1 winner. Sai, can we have it on the screen?
क्या बात, आप लोगों ने तो बिल्कुल रियल बना दिया इसको.
अरे congratulations, Sahil.
Sahil gets 1,500.
Congratulations, Sahil.
Thank you so much, sir.
Congratulations.
Now the section 2 winner is Dr. Neha Kumari. Do we have Neha Kumari online? Please put on your video. And Dr. Mamta, it's your turn to felicitate her
Sir.
and also interact with her.
Dr. Neha, are you online? I can't see her, I guess.
Yeah.
Neha, please put on your video inputs.
She's there.
Okay.
Yeah, go ahead, Mamta.
Hi, Dr. Neha, and congratulations. And let us know a little more about you. Where are you from, Neha?
I think her audio is off.
Good
Yeah.
afternoon, everyone. Thank you. And I'm from Himachal, basically
And
from
what-
Himachal. Presently studying in RPCs.
Okay, RPC here again. So what are you doing there, Dr. Neha?
I'm 6th semester,
Okay,
preparing for
that's
exam.
really, okay, that's really huge and a little embarrassing for us actually. Then congratulations, and let us give her the prize. Here is
Neha,
1,500 on your way. Yeah.
Neha, आपका आगे का क्या विचार है? आगे, are you interested in Cornea? How come you scored so well in the Cornea quiz? It's
Sir, we recently had unit leaving exams, so we study for that.
Is it Dr. Namrata Sharma and other people who have been inspiring you, Rajesh and all?
Yes, sir.
Is it only your forte? Cornea is the only forte, or the other subspecialties as well?
I like retina as well.
Oh, good. Someone to love.
Okay. Yeah.
Really happy being
Finally, someone is happy.
in this crowd of all cornea surgeon, anterior segment surgeon. I was feeling really lost. Thank you, Dr. Neha, for making my day. Now,
Thank
the
you, sir.
section 3 winner is Dr. Kavita, again from Delhi. Is she there live? Dr.
Yes, sir.
Kavita?
Yes, sir.
And so, Dr. Ramya, you can quiz her now.
Yeah. Hello, Dr. Kabita.
Hello, ma'am. Good evening.
Tell us more about yourself. Congratulations, firstly. What are you doing?
I am studying in RPC only in sixth. I am sixth semester exam going now.
So you're in RPC. Are you resident?
Yes, junior resident.
Nice. Congratulations. So are you interested in cornea?
Yes, ma'am. I am actually interested in cornea and refractive surgery only.
Oh, that's a loss for us as a retina surgeon. Congratulations, Kavita.
Congratulations.
Was you. And it's so inspiring that you, being a fifth-year resident, fifth semester resident, could score well and compete with the best of the people in this because remember, it's not only the residents who are playing it, but also the consultants and the people across the country. We are proud of you, dear.
Thank you, sir.
Okay, now the section 4 winner is Dr. Gaurav Majumdar from Kolkata. And it's time for Palak. It was your section to interact with this guy. Gaurav, are you live there?
Dr. Gaurav?
Sai, has it joined us?
He said he had some internet issues, doctor.
Okay. Okay. So this just show we can you can reflect his Amazon gift voucher. Yeah. Congratulations, Gaurav. We are missing you definitely on the online platform, and also you're missing the opportunity to interact with the greats in ophthalmology like Dr. MS sir, Dr. Virendra sir, and Dr. Rupal ma'am. The section 5 winner is Dr. Akshata Prakash from Bangalore. Welcome, Dr. Akshata. And it's time for Dr. Rupal Shah to interact with her. Ma'am, you have to felicitate her with her gift voucher and you can interact with her.
Congratulations.
Thank you, ma'am. It's a pleasure. It's actually an honor to actually interact with you live.
No, I think it was really nice. And so what are your interests, Akshata? What are the plans?
Ma'am, I'm currently doing my cornea and refractive surgery fellowship in Minto Eye Hospital, Bangalore.
Lovely.
I am from Bangalore.
And planning to remain in Bangalore.
Yes, ma'am.
All the best to you. I think
Thank you, ma'am.
You are already charting a good path for yourself.
Yeah.
Thank you so much,
So,
ma'am.
Akshata, you are through with your post-graduation and you are doing your fellowship, correct?
Yes, sir.
Okay. Who is your mentor there in Minto?
In Minto, it is Dr. Kiran Kumar. He was from AIMS.
Okay.
He's going to be really proud of you.
So we are really proud of you. And again, it means indirectly again an RPC alumni.
Yes,
It's the day of RPC, I believe.
Yes.
So congratulations to all the section winners. And so now the most coveted one, that is the runner-up for the whole session. And it is again from Delhi, Dr. Anand Singh Brar. Are you there, Anand?
Oh, yeah. Good evening, everyone.
Congratulations, Anand. And
thank you so much.
So Dr. Virendra sir, you are supposed to hand over virtually the gift, Amazon gift voucher of rupees 5,000 to this young guy and also quiz him something beyond.
Hi, Anand, and congratulations for this wonderful award.
Thank you, sir.
What are you doing and what are your plans?
Sir, I passed out of RP Center last year where I had undertaken a cornea refractive thesis between comparing SMILE versus LASIK. And currently I am now venturing more into vitreoretina surgery. So I'll be taking up a fellowship soon.
Very good. Prashant should be very happy.
I'm really excited now. Someone has moved out of cornea, really. Thank you. Anand, you have made my day again. Seriously. Because cornea ke beyond, there is much more. Yeah. Retina is retina.
Retina thoda deep.
Everything is important, actually. The eye does not know that it has been divided into so many parts.
See, but for a VR surgeon, I have the means right to withdraw your Amazon gift voucher if you do not talk.
Okay, I understand.
Congratulations, Anand.
Thank you so much.
Proud of you again. And the winner today, And the winner for today is Dr. Kavita, again from Delhi. She was also section 3 winner. So Dr. Kavita back again on the screen. And it's time for Dr. Srinivasan sir to speak to her and hand over the Amazon gift voucher.
Hello.
Yes,
Hello,
sir.
Kapita. Congratulations.
Thank you, sir.
So, what will you do with this money? So smart. So, what are you doing now?
I don't know. Actually, I don't know what I will do with this money, sir.
So go to, have a nice dinner.
Okay, sir.
Yeah,
Thank you.
Delhi, it is enough for a person. So, what do you do now?
Actually, I have exam in December, and then I haven't decided it. But after exam only, I will decide what I will do in the future, which branch I will choose. I haven't decided it. But I am actually interested in cornea and refractive surgery.
Okay, you are welcome to Madurai.
Yes, sir.
Kavita, you need now to acknowledge special thanks to Brain Teaser. You have already on a platter got a fellowship at the most prestigious cornea institute, that is Arvind Eye Hospital.
Thank you, sir.
The advantage of playing Brain Teasers, and really congratulations, very nice. And it is, I think, it is the greats like Dr. Virendra sir, MS sir, Dr. Rupal, who can inspire and make people from and create, nurture people at your age and make them a big person of tomorrow. Okay. So very proud of you, very proud of you. And again, congratulations. So thank you everyone, dear friends, all the guests, all my co-host, my host, my co-host, and Dr. Shilpi over here, who have been the brain behind the conceiving the whole concept of rather Brain Teasers. And I'm thankful to all the guests, especially MS sir, Sangwan sir, and Rupal madam, to spare their valuable time for us on this auspicious day, I should say. Thank you. It's an auspicious day because you all three came to our platform. It's a small platform. It's a new effort by our Brain Teaser team. So we are really grateful to you from the bottom of our heart. Thank you, Ramya. Thank you, Palak, Dr. Madhu, and Dr. Mamta once more. So let's call it a day. Bye-bye, everyone, and best of luck.
Bye-bye. Thank you, Prasad.
Thank you, sir. Srinivasan, sir. Thank you.
Bye.
Okay.
Yes, I. Hello.